Thanks very much, Randy. And I know we're running a little late, and they always say, don't get between an audience and lunch. But Gordon's told me I can speak for as long as I like, so we'll try and meet the balance somewhere. This morning, Randy and me, for the first bit of this morning, had a meeting with Ministry of Health and our collaborators that we work with, and that's why we weren't here. Interestingly enough, they had transport issues. The flights weren't working, and so they had to go to mostly virtual. And I work very closely with an organization called the Rural Coordination Centre, British Columbia, which is funded through the Joint Standing Committee on Rural Affairs. And we've been working in collaboration. I've heard this morning from the talks I've listened to, or the snippets I've heard, everyone's talking about working together. And that's what we're trying to do, is to work across the sectors. And we have the linked sectors, which is the non-profits and others, as part of that, which is why Randy and the Rural Centre are actually part of who we collaborate with. So I thought what I would try and do is give you a brief overview of some of the things that are happening in rural healthcare. And I know that the question I always get asked is, how can we get more doctors in our community? So I'm not going to give you the answer, but I'm going to sort of suggest something around about that. So the 4 areas that we're working with government on through our partnerships are around virtual care and telehealth, around team-based care, cultural safety, and I was really impressed at what Sheldon had to say to us and those of you that contributed to that conversation, and also around transport. So I'm going to touch on those and then try and give you some summaries of where we're landing right now. So this says hit the big green arrow. There we go. So first thing is access. So when you go into rural communities, the first thing people are saying to me is accessing healthcare is an issue for us. And so what do we mean by access? And one message, if I want to get a message to you, is the environment's changing that we live and work in, and we're going to have to think about things in different ways. So when you go into a rural community, you might go to a hospital like this or an emergency room, and you look at what's in it. You may find there's only an emergency room there. You may find a little bit more. This is actually in a smaller hospital with a number of beds. This is a birthing bed. And there's different resources in each of our community. You know this. Every community is different. Where are we landing with this? Now, Jerry, you will know where this is. This is Vanderhoof. And when I've been working with rural communities, what becomes very obvious is the solutions when the healthcare system gets a bit shaky are often in the hands of the community, and we need to often disrupt. When services have completely melted down, what's come from them is something different. And the future that we're beginning to see is one where we have partnerships, Northern Health and the doctors and others working together, different ways of owning buildings, different ways of employing the physicians. Our institutions are not there yet, but there is some disruption. So when I'm thinking of the future, I'm thinking of teams and how we incorporate teams and what it's going to look like. So that's one thing to be thinking about, is the idea of having the physician in the town that's been there for 35 years. That ain't going to happen anymore. We have to think differently. And working in teams may be one way. This is, some of you may know my colleague John Pavlovich. This is telehealth. This is in Takla. Takla is 4 hours north of Fort St. James, up a horrendous login road. And thinking about telehealth, you've probably seen, lots of people saying, right, we'll just get a dock in a box and we'll stick it in a room somewhere in our community. And we have the commercial entities out there thinking, here's a way of making money out of people's misery. This is not how we're seeing telehealth. And virtual care is something that, together with the health authorities and others, we work very closely with First Nations Health Authority and with other groups like Kari-Sakani Family Services on how we can develop better telehealth. This is a telehealth consultation taking place between TACLA and between a specialist in Vancouver General Hospital. And the main thing here is that there is continuity of care in this community. The same physicians go to the community. They don't live there. Well, John lives in Abbotsford, but he visits this community monthly, as do his colleagues. And there is a relationship based there. And I do not believe we can provide effective telehealth without relationship-based care. It's the most important thing. And being in the community and listening to the stories and working with the people is the way. And it doesn't matter if it's a First Nations community or a rural community. The continuity needs to come, and the relationships need to be there. So we have to think how, in a team-based environment and in a time when we don't have enough healthcare workers, how we maintain the continuity. And I'm very nervous of the dock-in-the-box type of things that are happening. We have just created with government and with Providence Healthcare what will be a center for virtual care excellence, and it will be relationship-based and focused on rural. So that's one of the exciting things that's happening. So we've got the technology, we know how to do it. Some of the work that we're doing is led by First Nations, and we have an opportunity to begin to think, how do we make that happen across the province? And then you get interesting things like this. Randomly, we've got AEDs. This is in the Chilcotin. There is no cell service, but there's 12 AEDs put there by the community and the physicians. So you might not be able to get an ambulance. You might not be able to call by help, but you can defibrillate yourself. So there's some great things happening. So I'll just let you read that. Does anybody know this quote? Does anyone like to guess when this was written? I can't. Somebody give me a guess. 1950. Close. 1916. So this was written by Mikhail Bulgakov, who was a famous Russian author, but also happened to be a physician. And in 1916, he was sent to rural Russia. And some things do not change. We have the same problems. This is a typical northern road. Now, you don't even want to travel by rail on this one. Some of you may remember this. This was from the floods when the Pine Pass flooded. So this is between Pine Pass and Chetwynd. And we have major problems in our country around rural transport. This is what we think. Now, this is, anybody got any idea what's happening here? It's a patient transfer, that's right. So this is somebody, this is on the Sunshine Coast, and they're going to hospital, and they've come from the hospital to the ferry terminal, where an ambulance comes from, Vancouver Island on the ferry, and they do a transfer between, and I'm thinking, we've got to do better than this. One of the things we've done in the Rural Coordination Centre is we're visiting all the rural communities in British Columbia, First Nations and non-First Nations communities. We visited about 90 of them now. We've another couple of hundred to go. We're going there to make connections and to understand. Transport stories are told by everybody. Everybody in your community will have a transport horror story. When I talk to the providers and all the other ones, everybody in the system is working really, really hard to make their piece work. But the system is not working for rural people. And so we have major challenges. And this is the other area where I think we're beginning to make progress. And it is a major conversation with government And one of the CEOs from one of the health authorities has been asked to convene a table of all the health authorities to begin to address the transport issue to see if we can make it better and safer for rural people. And when I speak to my physician colleagues, you know, they're in low-resource communities. Trying to get people out of them can be extremely difficult. They can be 6 hours on the phone trying to move a patient they know has to be moved. And this would create a crisis in Vancouver and all sorts of things. So we have a lot of work to do. We're working on it. And I'm sure there are lots of stories that you're going to tell us about that. So I was also, you know, coming from another country to here, to northern British Columbia, I really felt I needed to understand the history of the Indigenous peoples and the effects that had on them. Because when you go to our Indigenous communities, the healthcare facilities are very, almost sometimes not there. The transport difficulties are great. Some of our most vulnerable populations have the worst care. And that's not fair. And I was thinking of my own journey of trying to understand. I was taught by Indigenous elders and by others by being in the communities, by going there. This is Jackie Thomas, who you probably know. She's the chief at Sycus, and we were visiting the territory. I'm very fortunate to be taken by Jackie to go down the Stewart River to where the Stewart and the Nechako River join to their very sacred territory of Chinlac, where their original villages were. And it is, when you go there, it is, you do feel the ancestors are there. And you can see on the ground the lines of the old pit houses. 1,200 people used to live there. And interestingly, although it's surrounded by forest, the forest has not grown back where the village is. And it's by being in the communities, being at ceremonies, that has helped me understand things. And when we were there, you know, Jackie said to me, she said, you know, you can ask me any question you like. Just nothing is too stupid. And so we arrive, we go off the boat, she drums and sings. And I say to her, so tell me the significance of the song. And she said, oh, it's just one I like singing. She said, but we sing to let the bears know we're here. And you think, yeah, how simple, how logical, and how sensible. But that made us also think, how do we help people understand? So this is April the 5th. It's -17. It's on Takla Lake. And we decided to take the Dean of Medicine for an immersion experience into a First Nations community. And we brought him up and we ran a health show. And the young First Nations elder here, she provides the food for us, or for the medical people when they go up there. And so this is 6 in the morning, bringing out the morning catch to feed everybody that night. And you can see the Dean and his wife dressed in Vancouver appropriate clothing at -17. So they learned a little bit there, and you know, driving them up the logging road was another good thing. So to drive the roads, to be in the environment, there's no other way. So that's made us think, what do we do with our medical students when they arrive in northern BC? So they spend their first 3 months in Vancouver, and then they come to Prince George for the rest of their training. And we want to get them out into rural areas. The very first thing we do is put them in a bus, and we take them to one of our partner Indigenous communities. And this is what we do with them. And this is them at Snadden. And the chief and the nation put on a big welcome ceremony for them, and we get them dancing, and there are stories to tell. And this is their first experience in the medical program in northern BC. And we continue that by trying to ensure that they have opportunities to go for cultural experiences in different nations. There's lots of courses on cultural humility. I do not think they can at all reach going and being immersed and speaking with Indigenous people and learning what cultural safety is from their perspective. We have a lot of work to do there, and it's one of the things which I'm very pleased we're working with First Nations Health Authority and the other providers to try and find ways around this. And we work very closely with Indigenous physicians who teach us all the time how we can do a better job. So I don't need to tell any of you from BC what this is, but I think it's the changing contexts that I want you to think about. So as well as what the healthcare contexts are, we've got geographically changing contexts, we've got transport challenges, but we also have generational changes. We're working with healthcare professionals who are coming through the system who want to work in a different way. They want to work in somewhere where their families are going to be recognized, where they're going to be embedded in communities. And more, we're beginning to think we have to select the people coming into medical school and into the other health professions in a different way. Now, we've always, in the Northern Medical Program, we've always tried to find a way of bringing more rural people in. And since the early 2000s, UBC has had a very specific Indigenous admissions program. So 5% of the seats are set aside for Indigenous applicants. And I do not think we are yet bringing in enough people rural origin. We know, all the evidence is, if you grow up rurally and you go to medical school rurally, then you're more likely to work rurally. But the system remains discriminatory against both Indigenous applicants and against rural applicants. And why is that? Because if you live in a city, you're close to, if your parents have resources, you get supported to go to courses, to preparation courses. If you're from a poorer background, you're trying to earn money to keep the family afloat. So we have a lot of leveling, and we really need to find ways of bringing our rural and Indigenous students into post-secondary education and preparing them for health careers in a different way. I think we're making some progress, but we're not making enough. And I think when I look at the medical school I work for, which is the University of British Columbia, and it's got a campus just around the corner here, it's still a big institution, and it's a big research-based institution, and many of its decisions are still made in Vancouver. If we're going to change them, we need the help of people like you, because it's your voice, it's the voice of the rural people that will begin to be heard and be influenced. And one of the things we've been doing is to try and bring rural patients and rural voices into our admissions process. There's still a lot to do. So, how do you get more doctors? So this looks really complex. This is complex. This is what we're dealing with in every rural community. You try and think about this in the community you come from. I'm thinking of it as an ecosystem. That you've got the doctors, you've got the patients, you've got your community, you've got your resources, and you've got the external healthcare system. And we haven't got them together yet. And if you want to bring young physicians, young nurses, and people into your community, you need to be thinking of all of these things. Have they been trained properly? The people that go to, some of our students spend a whole of their clinical training in somewhere like Terrace or Vernon or Fort St. John, and they do their whole year there immersed in a generalist experience. They're fabulous clinicians, and they can handle the complexity of rural practice. They're ideal types of people, but you also need to think, how do we find accommodation for them when they first come? How do we embed them into the community recreationally? How do we support their spouses and their families? You know, how do we get, if they've got children, how do we get them embedded? How do you make them part of your community? And, you know, right now, the locums that come in aren't necessarily embedded. So if you can create the environment to create the relationships, you'll bring them and you'll keep them. So there are some communities I know that completely melted down, no health care whatsoever. And for some reason, now, people want to go there. What's that magic? What's that secret sauce that when somebody leaves, they have people falling over themselves to go and replace that physician? Now, there's not many places like that, but they are there. And what do we have to learn from them? And I think the resourcing and the support, that's where the telehealth piece comes in. Modern physicians are so connected to information, but they also need support. So a young doctor coming into an area needs mentored. And we now have, we can get an intensivist on your iPhone in 30 seconds in British Columbia right now. And so if you're working in a rural emergency department and you're the only person there and you've got a really difficult case and you need some support, you can get that person in there virtually. That's what's going to help recruitment and retention, is having those things. And you know, think, what can you do? My colleague John in Takla tell stories of Takla. He did a remote cardiac arrest resuscitation from Abbotsford in Takla. That patient is still alive. And they also did a remote shoulder reduction because the roads were too bad to get somebody out. And he taught the nurses. And they needed you know, when you're doing shoulder reduction, they need some brawn to pull the shoulder, and the nurses were quite small, so they just co-opted the local RCMP person to come in and haul in the arm. It can be done, but it breaks all the rules. It's innovation, and if we really start thinking about what is in the best interest of this patient right now, rather than what is in the best interests of the system or what is the safest way to do things, if we think of the patients, that's where we'll begin to make a difference. And right now, today, there are people out there making those decisions on behalf of patients. So that's all I really want to say. I'm happy to have a conversation, and given that there's free time this afternoon, if people want a conversation around some of these things this afternoon, I'd be happy to participate.